Okay, good morning everybody, good afternoon everybody. Everybody is now back from lunch. This is a topic which is very controversial topic, and a lot of thing has been done and said, and every surgeon who does arthroplasty is faced with the dilemma of controlling the post-surgery deep vein thrombosis and subsequent problem about pulmonary embolism and other issues. And a lot of research has happened, a lot of controversial papers have been published, and bottom line is we all of us want to be medico-legally safe. So there are certain questions which come to our mind based on the literature which you have, and we would like to have opinion of this august group which is here. We have hematologists, we have got a chest physician, we have got orthopedic surgeons of repute, and then we'll give what is currently believed in literature by the literature review. So, Bharat, you want to start?
Thanks. Wonderful. Gentlemen, Harish has started off giving you the background, and to the panelists, we are going to try our best to take the, how does this thing move? Okay, so we'll go phase-wise so that in 20 minutes we try to give you, the audience, a comprehensive take-home message. A quick question related to the overview of the epidemiology of DVT in arthroplasty. Is it a myth or a reality? By a show of hands, please, from the panelists. Just a moment. Why do they have to look back? Do they not have it coming there?
Can the screen?
Okay, anyway, they'll just have this in front of you because I was told each one of you have some amount of cervical spondylosis and we don't want to harass you there. So here we go. The question is simple. DVT and subsequent PE. By a show of hands, please. Do you think it's a myth or a reality? Those who think it's a reality, raise your hands. So you think it is not a reality?
No.
Okay, you didn't understand me. Yeah. So there you go. So everyone is agreeable that it is a reality, and no one would deny that. Look at that. Deaths due to VTE, more than 500,000, and it exceeds the combined deaths due to AIDS, breast cancer, prostate cancer, and even road traffic accidents. All right? So it is a reality. And especially in orthopedics, it is beyond doubt that THR, TKR, and hip fracture surgery have a minimum of 40% cases developing DVT. Luckily, the people who develop fatal PE subsequent to DVT is relatively very small. But even one life lost in 100 is indeed a devastating experience for that family and for the doctor involved in that particular case. So it is an important thing that we need to look at. Now the next question. Does DVT and PE exist in the Asian and Indian population? One by one, quick short answers because we want to cover the entire thing, starting with Rajesh.
Most certainly.
It does.
Yeah. Anybody against?
Anybody against who thinks that it is not existing?
Not a major problem.
It is not a major problem in the Indian or the Asian population? Everybody says that it is. I'm glad to hear that. Initially, few years back, it was common thing to be skeptical about कि अपने में नहीं होता है. In Indians, it doesn't happen. And the reason for this, when I traced the literature, in 1964, there were these couple of articles which said that absence of pulmonary embolism in Asians. And this was in the British Medical Journal. So it was a very reputed journal at the time. And this is the reason why that concept started gaining hold in our part of the world. But then in recent multinational epidemiological studies like the IDA study and the SMART study, which are international, highly controlled studies, IDA had 17,000 patients or more recruited. And these studies have definitively shown that DVT exists following TKR, THR, and HFS in our population. In Asian population. And in IDA, unfortunately, there was no Indian subset. But in the SMART study, there was an Indian subset as well. And here also it was quite clear that there were not only just DVT, but also PE as a definitive existence in our Indians as well. So now we are going to, having understood why we need to look at this, we are now starting out with the real subject of DVT. What are the prophylactic options available? Please, from the panel here, from their perspective, this is what we think that these are the three prophylactic options available. Any difference of opinion, any addition or deletion from these? Would you consider all these three as validated prophylactic actions available to the fraternity?
Yes.
Good. So then, what are the new trends in DVT chemoprophylaxis? And this is the heart of the matter. So, gentlemen, just to bring it to your notice.
Can we get opinion about individual faculty,
Yes,
especially
now,
orthopedic
from
surgeon?
here.
What exactly is the prophylaxis you use to prevent DVT in your TKR or THR patient?
We use everything, all three of those, the
Yeah.
early mobilization.
So, here, Rajesh, if you could point out which ones do you mean by all three?
So the early mobilization, the mechanical means, and the
Can you elaborate quickly? Mechanical means what do you use?
Mechanical means we put them on DVT pump and give them the dead stopping.
Okay, and do you use chemoprophylaxis? And if yes, how much, what drugs and what doses?
So
Fast, yeah.
We routinely use low molecular weight heparin, and we give it for a minimum of 5 days. But I must say that if some of the patients get a lot of bleeding or drainage, so in those cases, because the patient is mobilized, we discontinue them early. But usually
So
it's about
beyond
5
that, you
days.
don't give anything else?
Sorry?
Beyond 5 days, you stop everything?
Beyond 5 days, we stop everything.
Dr. Hodge, which of the three measures do you use routinely between the early mobilization, mechanoprophylaxis, and chemoprophylaxis in your group of patients? Which measures do you use routinely?
So I use all three.
All three.
And I think what also needs to be noted, the research shows there's a fairly big difference between knee replacement and hip replacement. So those treatments need to be varied, especially on the last one of those three. So the chemical base, and the American Academy of Orthopedic Surgeons has come out and said that aspirin works pretty well with knee replacements, but maybe not so well with hip replacements and proximal DVT. So you see a trend of doing more of the molecular weight, low molecular weight heparins with hip or the old-fashioned Coumadin warfarin treatment in hips, whereas in knees, Dr. Lotke proved after many years that aspirin works pretty well.
We'll come to that soon. Next, please. Any?
So I am not a surgeon, but generally when you are talking of thromboprophylaxis, you have to use all means which are present with you, and you have to look at the patient profile as well. So if you have somebody who's at risk for bleeding, then you would actually like to use mechanical measures much more effectively. If you do not have any reasons for a major bleeding episode to occur, then you could use thromboprophylaxis with drugs.
So, sir, in your case, which body's guidelines, if any, do you use or endorse, the ACCP or the AAOS?
We generally, as physicians, would like the chest physicians' guidelines, and we generally follow them, and they are fairly comprehensive.
Fair enough. Dimple?
Yes, and frankly, we more rely on early mobilization and pumps. We give ecosprin every patient. With a high-risk patient, we give low molecular weight heparin.
So if you felt there was a real risk, then you would give low molecular weight, otherwise you would be happy with aspirin.
Aspirin, yes.
If I could quiz you, why? Because, I mean, once you have decided that the patient has a risk of DVT or a PV subsequently, why would you differentiate between aspirin and low molecular weight heparin between your patients? Why not low molecular weight heparin in every case?
The reason is the bleeding. I mean, the reason is the bleeding because quite some patients have a lot of ecchymosis and ooze from the wound. So if the patient is ambulatory, mobile, coming in the consult.
So fair enough. So he says that it's because of a higher, his apprehension that low molecular weight heparin can lead to a higher chance of oozing or bleeding post-operatively. Would you think that there is a difference in the efficacy of aspirin and low molecular weight heparin? In other words, is it just bleeding problems which prevents you from using low molecular weight heparin in every case? Or is it something else?
No, the study, there are a lot of studies. I mean, it's difficult to judge.
No,
all
what
the
is your
studies
belief? I don't want to hear studies. What is your belief?
No, that's why I'm saying, I mean, the studies, so many studies shows that aspirin is equal to the low molecular weight heparin in total knee replacement surgery.
Okay, we'll hold you to that and we'll come back to that later in this discussion. Sir, after you.
Can we get quick opinion? Nobody doubts that we need mechanical and other early mobilization. Just tell us if you use chemoprophylaxis, what you use, how long you use, and why?
Being an anesthesiologist, I must tell that you see the DVT prophylaxis starts from the intraoperative period. And very important fact is that we must hydrate the patient fully, which sometimes is left. This item is left alone.
Good point.
Another important aspect is that the type of the anesthetic which we are using. Nowadays, a large number of people are using peripheral blocks, but I must tell from my own experience that Norexis blockade is the best remedy for prevention of DVT, because its evidence is almost 1A. So if we start with these hydration and Norexis blockade, then I think most of work has been done in reducing the incidence of DVT and of course the PE also. And as far as this pneumatic compression is concerned, it has certain indications, of course, where there is a chance of more bleeding, patients having hemophilia, having chronic liver disease, all these patients going for pneumatic cuff compressions.
So, sir, just a moment, so that we understand as surgeons, by neuraxial blockade, you mean, let's say, spinal anesthesia?
Spinal epidural, not spinal, but spinal epidural block, because this will help in prevention of DVT. It will help. It's worldwide known, and it has evidence of 1A, which is a very good evidence for that.
So instead of general anesthesia...
I'm not against the peripheral blocks, but if we apply spinal epidural more often, then of course the orthopedic surgeon will say, okay, my mobility will be less in these patients if we're using epidural for a longer time, but you can give a smaller concentration of local anesthetics in order to reduce the sensitive blockade only. So patient's motor blockade will be less and he or she can move perfectly on the first day even.
So the only thing is anesthetists are not very comfortable if you are aggressive in giving chemoprophylaxis to give epidural infusion pumps or...
Oh, that is true. That we have to, there are
So
certain
talk
guidelines.
to them that they are happy
there are
about
certain guidelines, when to remove the catheter, when to reinsert the catheter, all these guidelines are there.
Okay.
But of course, we have to simultaneously use pneumatic cuff compressions in certain cases, and also the chemoprophylaxis as has been said by them. So chemoprophylaxis, we do not use aspirin. Aspirin is only used when the patient is already on aspirin for a longer time. Okay, second day we can use aspirin. Because aspirin has a low evidence as far as prevention of DVT is concerned, or DVT or PT is concerned. So better to use low molecular weight dextroamphetamine. That is a wonderful drug, and chances of bleeding is not too much if we are using these very carefully. And we usually only we use only 2 to 3 days, not more than that. After that, we can push to oral anticoagulants.
Thank you, sir. Next, please, Raja.
My protocol is aspirin, 150 milligram from the first post-operative day till patient is discharged, and then after that first 1 month till they come back for the first follow-up. Till that time they take aspirin and then mechanical cough pumps during the hospital stay and then rapid mobilization. That's the protocol.
Next, please.
So I'm a vascular surgeon, so I'll prefer to use a low molecular weight heparin, so 1 milligram per kg body weight, not just a fixed dose of 40 or 60, what people use sometimes, which is very different to, you cannot use a 60 milligram low molecular weight heparin in 100 milligrams of 100 kgs of a person. And that should be continued approximately 3 to 7 days up to the time when we have a risk of bleeding, because we can, monitor it. Once this is done, then you should put it on the patients on the oral anticoagulation. And the choice is yours. You see, the latest ones are the best these days. And these should be continued approximately for 3 to 4 weeks at least.
Okay.
And then at 4 weeks, you assess the patient, if the patient is mobilized or not. And then you may have to continue it for another 2 to 3 weeks.
Okay, so we'll come to that, about the newer oral anticoagulants.
But another point I just want to make is aspirin should not be taken as a chemoprophylaxis. That's a totally different mode of action, and that should not be considered.
So we are coming to that. So that brings me to this next slide. And please focus for the panelists as well as for the audience. There is no doubt that thromboprophylaxis reduces risk of VTE after THR as well as TKR. In other words, look at this slide. The last bit is placebo. As compared to placebo, all the other 3 chemical agents have been proven without doubt to reduce the risk of VTE. In other words, it is effective action. But the question, the million-dollar debate that has been raging for the last few years is aspirin as effective as other chemoprophylactic agents? And our vascular surgeon colleague there has just mentioned that he doesn't think that to be an effective enough prophylactic measure. Am I right? This is what you said.
Sir, there is a lot of controversy in our field also, because because there are a lot of papers published which shows that aspirin is favorable. But if you look at the real percentage and the real things, there is a...
Just yes or no, because I'm coming to that. Was I right in perceiving that your personal opinion?
Yes, I will not use aspirin as a chemoprophylaxis.
Perfect. I wanted that clear statement from a vascular surgeon. So now, does aspirin have a role in the prevention of venous thromboembolism? And look here. There is no doubt that aspirin has been effective as compared to a placebo. Of that, there is no doubt. So aspirin is an effective anticoagulant agent, but how effective is the issue? Are there better or stronger agents available in terms of its efficacy of preventing VTE? And that's where Dr. I'm sorry I didn't get your name, but our vascular surgeon colleague is trying to lead his thoughts on this matter. And here, aspirin as compared to placebo, there is a definitive improvement, same in DVT as well as VTE. But look here, I know it's a busy slide, but look only at those highlighted white areas. As compared to aspirin, and look at only enoxaparin. Don't even look at, yeah, there you go. Don't even look at others, because enoxaparin, the low molecular weight heparin, has traditionally been accepted as the gold standard. Whenever you do a double-blind, international, multi-center, randomized trial, blah, 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 the new product introduction has to be compared in the form of whether it is as effective and as safe as enoxaparin. Anything better than enoxaparin is a definitive statement. And that is what has been used as the criteria for all the newer oral anticoagulants, which we will see in a moment. So here, as these things have been shown to be, this is a very important slide. These things here, it is very clear that they are more effective in preventing DVT. They are more effective in preventing DVT as compared to acetyl salicylic acid, which is aspirin in this column. So there is no doubt about that. However, statistical validation does not exist in the PE segment of the data. And that is critical to understand. Why does statistical significance not exist in world literature in the pulmonary embolism part of the same study? Why? Because pulmonary embolism as an event is so rare that to create the number of PE events required for a statistically validated large trial, the numbers are not available even on a collaborative world effort at the international level. And this is an important point to take home when we'll come to the last of these slides now. Just a moment, because we are running out of time, so I want to make sure that the audience goes away with a comprehensive understanding from this. What are NOACs? The ideal anticoagulant would be orally administered, predictable pharmacology, would not require monitoring when home, no interactions with drugs and food, and low risk of bleeding. This would be ideal. And this is what has happened over the years. This is a cascade, a coagulation cascade. Forget all the small reactions that happen here, important ones, but eventually what happens are two big things. Factor 10 is converted into active factor 10A, and that in turn ensures that it turns active factor 2A, and that converts fibrinogen into fibrin. So remember only these three steps. These are important in the coagulation cascade. Here, over the years, there have been drugs which have been brought out which are parenteral, which means injectable, which has a severe restriction on administration once the patient is discharged home, and then you have the oral. And amongst the oral, the newer ones have been dabigatran, which works here on factor 2A, and then you have these type of agents called rivaroxaban and apixaban, which acts as direct inhibitors on factor 10A. And this is the new generation, and they almost, not totally, almost meet the criteria of an ideal anticoagulant. Having understood this, now understand what are the suggestions of ACCP versus AAOS. Okay? Please take them through this if you would, please. Quickly. Okay, I will. Right. So, the ACCP and AAOS have the substance of their guidelines is crystallized in these four lines. Whether to use anticoagulation and what agents, the duration of prophylaxis, the usage of neuroaxial anesthesia, and the bleeding risk associated. The American College of Chest Physicians, they use these two words, recommend and suggest. Recommend was used whenever they found strong evidence. Suggest was used whenever they found relatively less strong evidence. Okay? So here, prophylaxis versus no prophylaxis. What is their recommendation? The recommendation is that you use. So in other words, they found strong evidence to recommend the use of chemoprophylaxis. Choice of agent, they did not find strong evidence. So they said, we suggest that you use one of these higher level of chemoprophylaxis as compared to aspirin or warfarin. Okay? So the ACCP is a bit little bit ambivalent. Okay? AAOS is completely ambivalent on this issue about the choice of agent. Sorry? So the duration, most of the people now agree that for knee replacements 10 to 14 days is a good duration, whereas for hips they recommend 35 days or almost a month. Yeah, give us a couple of minutes. We'll just wind it up because it's an important area. In bleeding risk, the ACCP says we suggest, once again, not recommend, but we suggest that only mechanoprophylaxis should be used if there is a higher risk of bleeding. All right? Whereas the AAOS, they used, once again, words like recommend and suggest, but they added 3 more words. The practitioner might, we are unable to recommend, and it is our opinion rather than anything else. Okay, so here we go. Prophylaxis versus no prophylaxis. AAOS, even here, the most fundamental of guidelines, the most fundamental, even here they say, instead of recommend, they did not find enough evidence, so they are saying we suggest. The choice of agent, they are clear in their, we are unable to recommend. So they are completely ambivalent about the choice of agent. They are not ready to go any further than this. The duration of prophylaxis, even here they say that we do not recommend or suggest or make any comment about a specific duration. Please discuss it with your patient and with the other referring physician and then come to a consensus. The use of neural EXSAA, they say we suggest that you use neuroaxial anesthesia as mentioned by our anesthetist colleague. So why are these differences there between the ACCP and AAOS? The main reason is, which I showed you that slide earlier, the AAOS does not recognize DVT as a valid surrogate indicator of PE. They said that when we did the literature search, there was no statistically validated, that means high-grade evidence available in the world literature to suggest that PE is reduced by the use of any agent. But the reason for that was that it is impossible to collate that sort of a data. Whereas, and that is why AAOS has given this rather watered down suggestions or guidelines. Whereas the ACCP says that we are ready to accept DVT as the mother of PE. So if we can reduce the rate at which the mother takes or is encountered, automatically the child will in that sense the incidence rate will be less. So those amongst us, if we think that this is a logical argument, we can accordingly shape our own clinical practice on this. Okay? So gentlemen, if you differ in any of these conclusions, please you are at liberty to question us, but we are synopsizing here. VTE is a definitive problem in patients in joint replacement, going for joint replacement in both the east and the west parts of the world. Early mobilization on its own, without any additional measure, is not a safe option, not a safe enough option. Mechanoprophylaxis on its own should be used only if there is a risk of bleeding, high risk of bleeding suspected by the physician. Pharmacothromboprophylaxis should be started early and continued long. Aspirin is effective as compared to a placebo, but not as effective as other agents for preventing DVT, although there is no conclusive evidence vis-a-vis the PE. Unfractionated heparin has been effective, but is now not convenient anymore. Low molecular weight heparin is the gold standard. However, it is being replaced for home use with the newer generation of drugs like rivaroxaban and epixaban. And this, in essence, gives you a comprehensive bird's eye view about DVT as is to be understood and practiced in our area of work. I thank you, panelists, for conducting and helping us with this conveying of this idea. Please, a big hand for each one of them. And any questions that you have, and if at all, 2 minutes. He's allowing us 2 minutes. This is an excessive liberty he's indulging the audience for.
Can I have a
yes,
comment?
Yes,
Yeah,
please.
See, we have to realize that these are ambulatory patients very often, and the series of events which lead to DVT happen on the OT table. So actually there should be coverage during the surgery, which we are not able to do because of the neuraxial anesthesia.
Yeah.
We don't want to give low molecular weight heparin before. So either you can actually use a mechanical, say a DVT pump on the table for a contralateral leg if you're doing a knee replacement, or like in total hip, if you are, when you prepare the femur by posterior approach, you internally rotate the femur, it has been shown there's a
So what
complete
is that?
obliteration of the
So you are
femoral
saying
vein.
start some mechanoprophylaxis on table itself.
On table
That
itself,
is the essence of what you are saying.
and chemoprophylaxis when the hip, when the femur is being prepared. That's what even Dr. Ranawat does.
Fair
Give
enough.
unfractionated heparin before twisting the limb or internally rotating when the femoral vein has been shown to get completely obliterated.
Okay,
So I think
okay.
that could be a big intervention which we are missing because of the neuraxial
Fair enough.
anesthesia.
I think that Rajesh has given us a good idea to start thinking about it on table and do it in a safe way which does not jeopardize excessive bleeding on table. Thank you. A suggestion from there, yeah.
So just one more point in that slide which you highlighted about that enoxaparin, which shows that DVT is it's highly sensitive for DVT and not for PE. The point here is most of the studies have found that DVT was diagnosed by venography, which picks up all the asymptomatic DVTs
Of course,
also.
of course.
So that is where the role of aspirin comes in. Look, aspirin is very good even in symptomatic DVTs, providing very good prophylaxis.
Oh yes, I agree. In fact, that slide about aspirin which I showed had two sections. One was for symptomatic, another was for the asymptomatic. But I take your point. Aspirin is effective both for symptomatic and asymptomatic DVT as compared to a placebo. No doubt about it. Any other comment? The last one. Last two.
I really like to comment again. Please, there should not be an idea passed to all the orthopedicians that aspirin is the only drug which should be used as a form prophylaxis. I will not agree with this.
I agree with
Please,
you.
because you see, end result I am seeing, we see 5 new patients every day. So you can imagine the amount of DVT what we have.
Agree.
And 50% of them are post-interventions.
Wonderful.
So please, and in the mobilized patients also.
Wonderful.
So I will not take aspirin as the only thromboprophylaxis.
I'm so happy that a vascular surgeon is present here amongst us because only then we end up getting information. Sometimes we get knowledge, but occasionally we get wisdom. And there we go. So one more piece of wisdom from some other parallel specialty colleague.
So I think two things that we must realize when you are talking of thromboprophylaxis and comparison. One is that this is a relative risk reduction. So you are not really making anything zero here. You are just bringing the probability down. Most of the pulmonary embolism does not occur immediately after DVT has occurred. It might take time. And therefore, if you have data which is confined to a smaller period of time, the 90-day mortality may be entirely different. So the difficulty that comes up is the way the studies are designed and the way you compare them. To my mind, prevention of DVT is an important component of planning treatment for any individual. Surgery is only one bit of it. What happens to this person after that is important.
Fair.
The risks of bleeding need to be assessed at the time when you want to use any form of treatment. If you have high risk, then you avoid anticoagulation and do something else. But if you have high risk surgery and low risk for bleeding, you must always use thromboprophylaxis.
Fair enough. So once again, the message from each panelist is it's a serious issue. Please focus on it. Understand the principles involved, the risks involved, and the gains involved, and make necessary adjustments in your clinical practice. Thank you.
Just one last comment. Are you confused enough by now?
Oh, well. Oh, that's the... Please, a show of hands. Those who feel completely confused. Completely confused.
Those who understand it very well.
Hello.
Those who thought
One more
they
question.
got a fairly clear understanding of what the subject is about. Please, show of
I'll
hands.
like to ask one question which will,
Well, at least
which
that's the
will
majority compared to-
remove some confusion in the minds of the audience. Here, sir. I would ask a question from both the panel masters. In how many cases, say, a patient within the age of 70 to 80, having an intertrochanteric fracture, waiting for surgery, say, made PAC fit earlier, say within 3 to 4 days, would you use chemoprophylaxis doing a DHS?
In my practice, all the patients who get with a hip fracture admitted in hospital waiting for surgery are always given chemoprophylaxis. They are looked after by my cardiologist. During the surgery and post-op period, 99% of them goes on chemoprophylaxis unless there is some bleeding disorder. All of them go on that.
All hip surgeries.
It's very difficult to justify not giving it in case something happens and you get sudden death on your hand in a post-op period, because there is humongous amount of data, either independent studies or company-generated studies, that you just cannot fight that case medically in a court.
I
So
think
you
you
have
are
to give it.
absolutely right. You see, your cardiologist is very good. You see, the risk of bleeding with any low molecular weight heparin, if you give in the appropriate dose, is very, very low. You see, you can imagine, we open all the blood vessels on heparin. So if we don't get bleeding, you will not get bleeding with using only the bones and the soft tissues.
I disagree with you here
Why?
because the bleeding for a vascular surgeon when you are opening the vessels and closing the vessels is different than bleeding from an exposed cancellous bone.
Yes, that
On a
I agree.
fractured
Yeah,
cancellous
that I
bone,
agree. Yeah,
there
yeah.
is no way you can stitch it up.
Yeah.
While a vascular surgeon is going to stitch up everything. So what they see, second thing, in a vascular surgeon case, a small thrombus can block that vessel which is repaired and the surgical outcome will be zero.
Yeah.
So they are very, very aggressive about anticoagulation treatment. While in orthopedic surgeon, you get oozing and the patient get hematoma and then bleeding. They are worried about opening the knee, infection, plenty of other
Infection
things,
is a
and
very
that can
important.
nullify your whole result.
So,
You see,
So we
that
don't have to
worries
be
me.
aggressive.
To conclude, because-
Let me finish. So important thing is, I don't think we should take a conclusion from vascular surgery and apply to orthopedic surgery, or conclusion from a physician about DVT in the chest because of medical condition and apply to the post-op hip or knee fracture patients, because they are totally different medical condition which you are treating. We have to realize that on one hand you are trying to reduce the risk of death because of DVT, on the other hand you are increasing the risk of bleeding. A medical case has no risk of bleeding as much as a post-op IT fracture patient. So you have to be very careful. That's what I said. It is such a confusing thing that you have to be medically
to conclude,
sure.
just to conclude, I think whilst there is absolutely a superb value addition by cross-pollinating viewpoints, approaches and experiences of different specialties, we need to tailor-make them and fit it to our own situation. But one message is clear, DVT is a risk in all these three categories of TKR, THR and fracture surgery, hip fracture surgery, and please be sensitized to it. Thank you very much, everyone.
Thank you very much.
Sir, one question. Excuse me. Thank you, all the moderators and the panelists.